Good evening, everyone. This is Ralph Marucci with Empire Surgical to discuss with you a rotator cuff repair. The rotator cuff is a very fascinating and important part of the body, especially in the cases of athletes. It allows a pitcher to throw a pitch, it allows a swimmer to swim, it even allows a tennis player or a bowler or any type of athlete you could pretty much think of make that motion that's so important to their craft. So what happens when one of these athletes experiences what we consider a tear in that cuff? How will that affect their ability to play that sport? There are several ways you can tear a rotator cuff. In most cases, especially in the cases of athletes, you're dealing with an acute injury, some sort of trauma. They fell on an outstretched arm, something along those lines. Could have been an accident of some type. And of course, you're dealing with also chronic issues where over time there is a tear. Where maybe the acromion has a hook. There are 3 stages to that, and we'll get to that a little bit later in our repair. But for now, let's discuss an actual repair itself and walk through this step by step. We're going to break it down to 5 major categories, starting with our actual drafting of this rotator cuff. First of all, the patient will be laying in a lateral decubitus position, which means that they'll be laying sideways with their arms straight up in the air. There's also another position called beach chair, where they'd be just, essentially, if you could picture someone sitting in a beach chair, that's what it would look like. So certain assumptions will go into place here. First of all, there's no labral tear involved. We have a standard horizontal U-shaped tear in place here, in which we'll be using a single row fixation with a double loaded suture or helix, and the patient is, let's just hypothetically say, is a male around his 30s and has suffered a tear in the supraspinatus portion of the rotator cuff, and let's just check it out procedurally and how we would go about this. So first and foremost, we want to draw out the acromion and the clavicle portion of the shoulder, pardon me, and from that point, we would like to take a 2 by 2 centimeter measurement from that acromion to label where our posterior portal will be. We will go 2 centimeters inferiorly and 2 centimeters medially, and then at this point we will be able to enter in with our arthroscope. Once we enter into this space, it's the joint space, the glenohumeral joint space. We will notice that our glenoid is on the right, our humeral head is on the left, and of course our bicep tendon is located at 12 o'clock. There may be some fraying here, some cartilage or some bursa at this point that needs to be cleaned up, and we will definitely be going in to clean that up. But also, we'd like to make sure we can view the space at our utility portal, which is anterior. We come around to the front using a spinal needle. This needle is very, very important. We will be placing that in just below where the biceps tendon is. Again, we can see where we are from our portal in the back. We will be entering in just below that biceps tendon, and we will place our cannula in there so we can use this anterior portal as our utility portal. Now, once we enter into this space, we'll move in with our vapor, which is a fascinating product by MyTech that is, will use a sort of a burning method to remove any type of scar tissue, as we mentioned, or anything that's been frayed, if you will, in that space, to help clean it up and give us room to work and identify our tear. Now, once we've cleaned it up, we will move subacromially, which is superior to our space right now, and use a proline stitch to help identify our U-shaped tear, which again is located at the supraspinatus. It is a small tear. Again, the patient fell on an outstretched arm and is a slight impingement at this point. We send our proline stitch up there, and we will now go into the subacromial space and allow ourselves 5 to 7 at least millimeters of working space so that we can operate cleanly and efficiently. Using a burr, we will shave down any bone that may be in place, and again, using our vapor, remove any scar tissue or tissue that may be in our way. Now, we'd like to set up our lateral portal at this point, which is going to be our working portal for our repair. Coming laterally, we will make another incision, but before we do that, we want to once again use our needle to take care of anything that may be in our way. We don't want to actually puncture and damage and just sort of poke around. Going at a 45-degree angle, slightly anteriorly or posteriorly, depending upon your viewpoint, your comfortability, we will make our incision again at a 45-degree angle. Our goal is to bring our tendon back down to the anatomic position, which is located both on the anterior margin as well as the greater tuberosity. Ultimately, we're doing a single row repair, so we'll just be hitting the greater tuberosity. In a double row repair, we would also be tacking down our anchors onto the anterior margin. Once we have once again made this incision, we now are able to utilize our working portal. We will then place in our anchor on the single row of the greater tuberosity. By using our burr, we will once again create a bloody bed, which will eventually help us with our actual healing process. Blood will serve as an adhesive to ensure that the anchor will not go anywhere and the tendon will remain intact. So it's very important that we create this slight blood at this point. We will now load our sutures, which come already with the anchor. We have 4 limbs altogether on this one anchor. Remember, we said it's a double loaded suture here. 2 of those sutures will be blue, 2 will be purple, and our goal here is to affixate a knot onto the anchor to keep that anchor fully intact and in place. So the first thing we're going to do is using our lateral portal and our clamp claw, our crab claw, pardon me, we will pull out our first suture through the lateral portal. I should also mention that we're using a simple stitch here. A simple stitch means that one suture is being loaded through the tendon while the other one goes over, as opposed to a mattress stitch, which would find 2 sutures going through the tendon. So again, we're taking one suture and loading it out, our cannula in the anterior portal, and then pulling it out with, we're going to load into our espresso gun and reload it back into the gun, fire that suture off, so this way it's we have 3 sutures out of the way and 1 suture out of the anterior portal. We're going to come back in and repeat those steps with the following 3. Tie our knot on the outside, slide that knot down into the into the lateral portal, and tack down and make sure that our anchor is fully in place. Do some final cleanup and leave ourselves with a clean rotator cuff fully back in its anatomic state. I want to thank you very much for taking the time to listen to my video, and all your questions and comments are certainly welcomed and appreciated. Thank you very much.